Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place where I get to spoon feed you guys the latest and greatest of emergency medicine. Now, this is the audio version of the past week summaries, which this week were brought to you by our authors Samuel Rouleau, Caitlin Nicholson, Alex Clark, Megan Hilbert, Jonathan Brewer, and of course, Clay Smith. Okay, let's get straight into the first article, which was titled Personal Hemodynamic Resuscitation Targeting Capillary Refill Time in Early Septic Shock, the ANDROMEDA Shock 2 randomized clinical trial out of the JAMA. Okay, many of you likely will remember ANDROMEDA Shock 1, which was a big, important RCT which looked at capillary refill times versus lactate levels. And it really put cap refill, on the board. Something so simple as looking at a capillary refill time seems to do a pretty good job of being a resuscitation target. However, I know we've gone away from a lot of these sort of target-based or goal-oriented resuscitation techniques because, they don't seem to make that big of a difference. But it's still interesting to see that cap refill time does a pretty good job. See, the problem with the original Andromeda trial, though, was that none of it was very personalized. All the people in the intervention group got pretty well the same thing. However, now we've got Andromeda 2, and now we've got really more personalized care based on exactly how they're responding to what we're doing to them. So this isn't really just looking at cap refill time as a measure of how these patients are doing, but it's also testing a whole bundle of care. This is interesting, and I'm going to talk about it in a second, but also super useless. Because unless you're adopting the entire bundle, then you don't know what's good or what's bad. So it's hard to take away from these trials sometimes. Now, what they had was 1,500 patients across 56 hospitals and 19 countries, randomizing patients to what they called personalized hemodynamic resuscitation protocol, targeting capillary refill times, trying to get it over 3 seconds, versus just usual care, whatever these sort of local or international protocols were. So now let's talk a little bit about this bundle. What they did was they had patients, you had to be, hypotensive, in shock in order just to qualify for this. But then they looked at the capillary refill time. And if it was normal, then, you don't do anything. But if it's not normal, then they looked at the pulse pressure difference. If the pulse pressure difference was less than 40 millimeters of mercury, then they assessed if that patient would be fluid responsive. If fluid responsive, they gave fluids. If not, then is the capillary refill time still abnormal? Then they moved on to other assessments. If the pulse pressure was more than 40, then they looked at whether or not the diastolic blood pressure was less than 50. If it was, then they just increased the dose of norepinephrine. Now, what were those other tests? They looked at cardiac dynamic functioning on echocardiography, and then if it wasn't doing so well, they used targeted specific treatments. If it was doing okay, then again, you would assess for fluid responsiveness, maybe give fluids. And then there was a few other things. You could do a dobutamine test, or you could try raising their mean arterial pressure by a little bit to see if that helped with capillary refill times. So that's, in summary, pretty much what the entire protocol was for the intervention group. Now, they tried to recruit these patients early. They're supposed to be, sick ICU patients. And they only ran this entire protocol, this entire intervention for 6 hours. I don't know what to feel about that. I don't really care about just 6 hours, especially when you're looking at 28-day outcomes. What are you doing? I don't understand why you would do this for just 6 hours. Why wouldn't you just keep doing this for their hospital stay? It's probably a lot of work to keep doing this, but still, 6 hours? Come on, guys. What did we expect to see? The primary outcome was a hierarchical composite outcome, and they calculated the win ratios. And it did seem to benefit if you were in this cap refill time intervention group that was primarily driven by a lower duration of organ support, which it's sort of hard to tell, but seem to be from kidney replacement therapy, which is probably one of the least patient-centered ones for like the patient caring that much that they're on this. They don't really have to do much if you're a critically ill patient who's in the ICU. If you're just hooked up to CRT or dialysis, it's not a huge quality of life difference for you probably if you're still in the ICU. So I can't say that I care that much about composite outcomes in general, but for this composite outcome particularly, not that important to me, especially when the mortality rates were, well, pretty much the same between the groups, or they were not statistically significantly different. If you look in their supplemental figures, you see that pretty much all of the measures of most things seem to trend towards being the same by even about 24 hours out or just 3 days out, and that this 6-hour protocol isn't creating that much of a lasting effect. There wasn't a difference between hospital or ICU length of stay either. So I don't know why I would expect 6 hours of management in this way to get your capillary refill time normal for 6 hours to really have that big of a trickle-down important effect on the rest of your hospital stay. They say that a frequent assessment probably didn't improve the intervention group because there was a difference in the amount of fluids and vasopressors that were used. But it's not the actual looking at them that makes a difference. It's the fact that you do something when you look at them. So if there's differences in the fluids and vasopressors used because you were looking at these patients more, then that kind of proves that there's a difference based on looking at these patients more. So, either way, the outcomes are not significantly different in a way that I care, but it's just weird to claim that looking at these patients more frequently and assessing them more frequently because they're in the intervention arm isn't having an effect, when normally, well, we think that it would in an unblinded trial. I am interested globally in this sort of resuscitation protocol. I'm not going to be adopting this into my practice, but I do like to see people sort of design well thought out algorithms for resuscitation. What we want is to show that they're better than usual care to have a systematic approach like this, which we're not seeing here. But hopefully one day we will find something that is structured and systematic that we can, use clinically that would be better than just usual care. We didn't find that here. So ANDROMEDA-2, this is a big trial. This is an important paper that's come out, especially as a follow-up to ANDROMEDA-1. However, I'm just not seeing much to take away from this. If this had been a protocol that lasted more than 6 hours, and maybe then we would have found some differences from it. But again, I'm just not seeing that here. This strict protocol for early resuscitation just to have a normal cap time, well, it doesn't seem to be that important on more important outcomes further down the road. If this could be better validated, then heck, I guess I'd have to start walking around with a microscope slide in order to do a proper blanching and cap refill time test. But, those days haven't come yet. In a spoonful, they did almost enough to be a great trial. I'd have liked to see this extended past 6 hours in the future. However, in this Andromeda Shock 2 trial, I did not see any important differences between the intervention and the control group, so I'm not going to be incorporating cap refill times into my usual resuscitations just yet. However, if you already do, then heck, you've got a great protocol here to follow. Okay, then let's skip to the third article, titled Deferring Arterial Catheterization in Critically Ill Patients with Shock, out of the New England Journal of Medicine. This is the EVERDAC trial, which randomized patients between getting an ART line and using non-invasive blood pressure management. Now, ART lines have been talked about quite a bit. If you listen to MRAP, then they've covered this topic a few times in the last couple of months. And so they've talked quite a bit about ART lines. I suspect once they get their hands on this article that the topic will come up again. Journal Feed's coverage of articles is a little bit faster than MRAP's, so you're going to hear it here first. And then if you also listen to MRAP, you'll probably hear it there later. Now, ART lines do have a bunch of advantages. They give moment-to-moment blood pressures and not have to wait a couple of minutes between measurements. They're great for blood draws. And honestly, they're just nice to have. It's nice to have that great measurement, especially if your patient is, peri-arrest or something like that. You don't have to feel for a pulse. You can see that they have a pulse on the art line. So there's definitely some advantages. The disadvantages, though, of course, are that you've got to poke someone. You've got to have this catheter that's living in their hand, or wrist, or wherever you want to get it into the radial artery, or other artery. It could be the femoral as well. And this comes, of course, with complication risks, hematomas, infections, stuff like that. So this trial wanted to compare whether or not putting in an art line early or just continuing with non-invasive blood pressure management would make a difference for patients. This was an open-label, multi-center, non-inferiority trial done in France, the EVERDAC trial. How they got those letters in there is a bit convoluted, but it doesn't even sound that good, but I guess you can say it though. EVERDAC. Not too bad. Anyways, they randomized about 1,000 patients who were critically ill in the ICU. And they either got an art line, which is supposed to be placed quite soon after randomization, within 4 hours, or they were randomized to non-invasive blood pressure management, in which case if they already had an arterial line, it had to be removed within 1 hour, and you were not allowed to use an arterial line for the next 28 days. This could be overridden in some circumstances, but for the most part, there was just no art lines for you. As for the inclusion of patients, I don't love to see when the equivalent of 20% of the cohort was not included due to physician decision, but I'm going to try to assume that that physician decision was not biasing the group of patients that were actually included in the trial. And for the primary outcome of 28-day all-cause mortality, both groups were the same. They were significantly non-inferior to one another, but honestly, overall, there was no significant difference between the two groups, so I'm just going to call them equivalent and sort of ignore the non-inferiority bit because I think it's a little bit silly. And the group that actually had the point estimate, which was higher, was the invasive group, so more of the patients with art lines were dying, which is, I guess, on the surprising side. Although none of them were dying from complications of the arterial lines, so don't get too worried about that. The safety outcomes were relatively similar, although of course the patients with more art lines had more hematomas and more hemorrhages related to arterial catheters, and there was not a lot of complications due to non-invasive monitoring. However, patients did report that there was more discomfort if they had non-invasive blood pressure measurements. I guess all that squeezing when you're in an ICU bed is just not very pleasant. I think I'd have an easier time sleeping if I just had an arterial catheter that didn't move around, it didn't squeeze me at all times of day. Honestly, something that I thought would be different but wasn't even different was the durations of vasopressor use. Not even that was different. Now, the authors thought that perhaps art lines are not being capitalized on enough. There's a lot of information that you can get from arterial lines that people don't routinely actually get. But you could say the same thing about Swan-Ganz catheters, and we don't really use those routinely anymore either, and I don't think anyone's missing them that much. Probably a couple of people, but we already threw those ones out, and it didn't seem to impact patient outcomes. So not that I think that arterial lines are going to be completely thrown out. It's not like we never use Swan-Ganz catheters anymore either. But it seems like routinely using them isn't benefiting our patients. So the decision still comes down to you. I wouldn't put one in every patient, but there are circumstances in which it might be beneficial. Can you not get a good blood pressure reading on this patient with a cuff? Then perhaps in that patient. Do they have a brain or spinal cord injury and you want really tight blood pressure control? Again, perhaps appropriate. But it's all going to come down to your decision, and it does not seem that it systematically benefits patients. In a spoonful, this large, well-conducted study randomized patients to invasive versus non-invasive blood pressure measurements in the ICU, and they did not find any difference in mortality or really many outcomes at all to be different. So, non-invasive blood pressure measurement seems to be, well, just as good as getting an art line. Okay, that's all the articles from this week. Let's do a quick wrap-up. From the first article, ANDROMEDA-2, it has a galactic name, but it was only done on a tiny 6-hour timescale. It was positive, but really just for non-patient centered outcome of vitals support. So it's not exactly a hit out of the park for cap refill times. And then from the third article, this is strike one for arterial lines. They're a fun tool, but they do not seem to give a mortality benefit to your patients when used in the ICU routinely. Now, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. If you're a subscriber to the journal feed, then we offer more articles every week delivered to you through this podcast. You missed 3 articles, and they were interesting, of course. What were they about? Well, one was talking about the benefits of initiating pressors early. Another one was a review on nitazines, what you need to know about these new opioids. And lastly, just more information on ketamine for treating pain. Does sub-Q work? Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.